हाँ Tipul or हाँ Timul Verma or somebody. He said about that psychological, impact that they always proactively like to create. It is a part of the strategy as well. So I mean, his presentation was like, too mind blowing. It was like very complex. Mhm. याद है तुझे उदय? Psychological trauma in the warfare.
Where?
Where? In Chinmay's program, he spoke na, commander.
Yeah.
This Mandeep has already warned me. मैं बीच में चला जाऊंगा तो आपको कुछ बोलना पड़ेगा. Mandeep, it will not happen like that.
Hi, Uday.
Hi, you are at work as yet?
No, I've just reached home.
Reach home.
It's Ramadan, no? So 6 hours work only.
Yeah, good. So आराम है तेरे को थोड़ा. So which do I say that you're attached as a fetal consultant to which unit?
Emirates Hospital.
Emirates Hospital.
Yeah.
Okay, in Dubai.
In Dubai.
Hi, Shantanu. I think it's 8 o'clock. Should we start?
Yes.
Yeah.
Jibak and team?
Sure, sir. Sure, ma'am. We can start.
We'll make it like
So
start the lamp.
please light the lamp.
Slide now.
Yeah.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य दृष्टे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Good evening and a very warm welcome to all of you. On behalf of Dr. Hema Divakar and Team Artist, I welcome you all to this webinar, wherein we are talking how medicine meets technology, translating prediction into prevention. The webinar is hosted by Pharmet. Dr. Hema Divakar will open the session by setting the context. We then have a clinical keynote address by Dr. Mandeep Singh, and the session will be chaired by Dr. Uday Thanawala and Dr. Milind Shah. Next, we have the tech keynote by Dr. Shantanu Pathak. Dr. Lavanya Kiran and Dr. Parag Bhame will chair this session. I now have the privilege and honor of introducing Dr. Hema Divakar to you. Dr. Hema Diwakar is the CEO and chairman artist for her. She's the division director, FIGO, Well Women Healthcare.
Thank you very much, Rita.
I hand it over to Madam now. Yes,
Thank
ma'am.
you. Thank you so much. I grabbed it before you handed over. Thank you. So, welcome to all our dear delegates. Many of you I see have joined well on time. And the whole impact of this session is going to be bringing home the fact that the future is now. As all of you know, there are many visitors from overseas who are totally taken aback with the way India has leaped forward with the digital innovations, and where, as Rita said, the technology meets medicine, the healthcare could indeed be transformative. We have a very distinguished faculty today, the silos being broken, the health tech getting married to the healthcare providers. This is a heady mix of very distinguished faculty which have the first-hand experience of innovations to implementation. We also have the privilege of having Dr. Uday Thanawala and Dr. Milind Shah to chair the first session. Dr. Uday, as we all know, is the past chair of the Indian College of Obstetrics and Gynecology. He's a consultant at the Thanawala Maternity Hospital, Navi Mumbai. And the concept of Knowledge Cafe, as we were speaking a long, long time ago, we said to each other, a lot can happen over coffee. And the Knowledge Cafe series, hosted by PharmEd, is one of the finest examples of a lot of things happen, or even many times in a month, with respect to what the newer advances, the nuances that technology can do in today's era. The other distinguished chair is none other than Dr. Milind Shah. Though he's an MD in OBGYN, he took this leap to train and be a fellow in fetal medicine, and today he stands proud as a dedicated feto-maternal specialist in the town of Satara, which also brings home the point that reaching the last mile with very skilled personnel in remote parts of our country is definitely going to be a game changer. I will now hand over to Dr. Uday, who is also a personal friend of our keynote speaker today. We all have grown up together. Dr. Mandeep Singh will be fondly introduced by Dr. Uday. Uday, please.
Thank you so much, Hema, and very nice of you to have me here to chair this excellent session which you are having on technology and advances in OBGYN. So it's a privilege to introduce Dr. Mandeep Singh, because as Hema said, Hema, Mandeep Singh, all have been together since a long time. In fact, Mandeep Singh was in Navi Mumbai when he started off his practice, then went to UK. In UK, he did such phenomenal work, and he was attached with Professor Kipros, where he gained so much of experience in fetal medicines, did a lot of research there, and then branched off and started his own one unit in Abu Dhabi, where he was doing fetal surgeries. Now, that's such a new area which he went into, repairing the spina bifidas and doing in utero repairs of spina bifida, and excellent work which he has been doing in Abu Dhabi. And he's recently shifted to the Emirates group in Dubai, where he is the fetal medicine consultant there. So he has a whole knowledge and experience in fetal medicine, and he is going to enlighten us upon the early prediction in high-risk pregnancy and what changes outcomes, what is actually important when we say inverted care, inverted pyramid of care, what it actually does and how we can do it, like Hema said, at the grassroots level, how we can do it here. So welcome, Mandeep, and I request you to please take over and start the lecture, your lecture. Is Mandeep there or he's logged off? He was here.
No,
He's there.
he's here.
Mandeep, can you hear us? Are you there? We can't see we can't see you or hear you. I'll call him up.
So, in the meanwhile, if I could have some initial comments from Dr. Milind Shah, the other chairperson for this session. Milind, please. Your experience in the patient's perception of what fetal medicine could do. I think Mandeep is already on, so we will reserve your comments for very soon after his lecture. Mandeep, go ahead, please. You're muted, Mandeep. Yeah.
Sorry, something happened to the internet. Please bear with me if I get disconnected. I will connect immediately. There's a lot of funny stuff going on, the GPS goofing and all that stuff. So nothing is working as we planned, but hopefully we
But
will be.
are they still bombing Dubai?
Yeah.
Oh my
Yeah.
God. Oh
It's
my God. So
it's been going
so
for
you
a
are in a
few days.
war-like situation there.
Perfect. Can I
Yes. Yeah. Yes,
perfect.
Mandeep.
So Hema asked me to talk about early prediction of in high-risk pregnancy and what truly changes the outcome. And I think in the introduction, Hema mentioned that the future is now. So I'm not going to talk about something very new or something that we will never do, but I'm going to talk about things that we already know and we already use them in practice. But there may be some small changes that may have to be done to make those interventions effective. And I think those are the ones that will actually change the outcome of pregnancy. As we move forward, I think we all have heard about this terminology, precision health, precision medicine. Precision medicine is sort of being talked about everywhere and in every specialty. But I was trying to look at papers if there is precision medicine in obstetrics, and I couldn't find one. And I was thinking as to what in obstetrics, because if you look at what precision medicine means, then it means that it's the transformation of medicine or obstetrics into a predictive specialty where advances in imaging, biomarkers, data science allows clinicians to identify high risk pregnancies long before complications develop. And I think obstetrics was one of the specialties where we did this long time ago, whether it was for screening for preterm labor, whether it was screening for preeclampsia, whether it was screening for simple things like postpartum hemorrhage. We were doing this for a long time. And if you look at how precision medicine works, so every pathology goes through 4 stages. And instead of waiting for a stage where a clinical disease manifests and we make a diagnosis, we have now shifted from going to the stage of subclinical disease. And in subclinical disease, just to give an example of preeclampsia, we try and find out women who already have preeclampsia but may not be clinically apparent. But in precision medicine, we probably go a stage before that, which is the stage of susceptibility, in which we try and identify women who may, if they become pregnant, develop preeclampsia, develop diabetes, develop various complications. And I think that's where we are looking at. We don't want to identify subclinical disease. We want to identify women who are susceptible or who are at the risk of developing diabetes or preeclampsia if at all they become pregnant. So precision medicine, basically you tailor diagnostic and therapeutic approaches based on characteristics of patients, recognizing that not all tests or treatments will have the same role, because every patient will have its unique genotype, environment, and phenotype. So the treatment may not be same for everybody, the dose may not be same for everybody, and the duration of medication that we give may not be same for everybody. And that's where we need to bring obstetrics in, because I think some of our or majority of our interventions that we do are sort of tailor-made for everybody. Now, for the purpose of today's lecture, I was going to try and talk about four things. One is emerging technologies, and I know Shantanu is going to follow up with his lecture about new emerging technologies. But I was going to talk more about the clinical aspect and look at ultrasound, some Dopplers, biomarkers, and one of the examples is preeclampsia, of course. The second was about how prediction in translating, how we can predict and translate that into prevention. And I was going to talk about Vasa previa and a few other things. Innovation in improving obstetric emergency, and that's a very interesting part. At least I find that very interesting. I I do more of fetal medicine, but obstetrics remains the core of our specialty, and we can't get away from doing routine obstetrics and obstetric emergencies. And then look at the future of maternal fetal medicine and the role of fetal therapy. So the emerging technology story doesn't start just during pregnancy, but it starts even before pregnancy. It does not start with just one patient, but it probably encompasses the entire population, because electronic health records, data of pregnant women, and user-rendered information outcomes becomes the core for us to base our prognostication on. As Hima mentioned, uh, uh, today the power of obstetrics or the power of medicine is data. And I think that's the pre-pregnancy phase or the pregnancy phase where women enter into pregnancy. The data is very important. Looking at the second phase, which is the antenatal phase, potential for recognizing infections, diagnostic, understanding bacterial resistance, a number of things that we do in pregnancy, including screening and prophylaxis. Labor, of course, we're going to talk about monitoring of the baby today and maternal understanding of maternal physiology, postpartum, and of course neonatal care. Number of interventions that have come to monitor the babies remotely, monitor the mothers remotely, which have changed the way obstetrics works today. Let me start off with the most commonly talked about lecture. Every meeting or every conference you go, we cannot get away without discussing preeclampsia. So hence I just put one slide of preeclampsia. This is mainly about the revision of our concepts of preeclampsia and where we are today. So we know that if every woman was allowed to remain pregnant for a longer duration, they would develop preeclampsia at some point. In high-risk pregnancy, they develop preeclampsia slightly earlier than they would normally develop preeclampsia. And we know that there are certain women who are at risk of developing preeclampsia or high blood pressure in pregnancy. And those can be identified by a number of factors. Maternal factors like blood pressure, uterine artery, pulsatility index, biophysical measures such as the MAP and uterine artery pulsatility index, biochemical tests such as PLGF and PAPI, and we know all of that. Know that if we combine all of these, we can predict at least 80% of women who are going to develop preeclampsia. We also know that now we have a good detection test. That is the triple test, mean arterial pressure, uterine artery, and PLGF. And we also know that if we give these women aspirin in the dose of 150 milligram daily, we would be able to prevent early severe preeclampsia in around 80% of the women. And if you put these figures into perspective, then it's very powerful, because if you can prevent preeclampsia in 80% of women who were going to develop preeclampsia, early severe preeclampsia, then there will be only 2 out of 10, or probably 1.5 out of 10 left who will develop preeclampsia. So almost you are at a stage where early severe preeclampsia would be almost eradicated. Not completely, but almost. However, there is a problem. Why has it not happened? We have been giving aspirin to everybody. And when I say everybody, it's literally everybody, because anybody who has any risk factor gets 150 milligram of aspirin. We'll come to why. But the thing that we are missing is probably compliance. This study also showed that if you look at the first graph, that if aspirin is used in these high-risk women, and if the compliance is more than 90%, only then it prevents preeclampsia. That means that if preeclampsia is not taken every day, or if the compliance is less than 90%, then the effectiveness of aspirin may not be that great. The second point that has just come up in a very recent paper, which has just been published this month, is that when we risk assess women, and if the risk of preeclampsia is more than developing preeclampsia, aspirin 150 milligram prevents all cases of preeclampsia up to 37 weeks gestation. That means in the super high risk, when we call this super high risk, this is a term that I've sort of put for women who have a risk of more than 1 in 20 in developing preeclampsia. In these women, preeclampsia will not develop up to 37 weeks. And if the risk is less than greater than 1 in 20, then aspirin prevents preeclampsia in up to 35 weeks gestation. That means we also need to monitor these women for late preeclampsia. So that brings about 2 points. One, compliance is very important, and risk assessment is very important. The problem with us using aspirin universally is that one large number of women will receive aspirin, and I completely understand that if it's not going to cause any harm, then what's the problem? However, there is something which will probably come up is an aspirin fatigue, where women will take aspirin, but the compliance may not be greater than 90%. There's also aspirin fatigue amongst physicians who will give aspirin, but may not insist on this part that the compliance needs to be more than 90%. And if we do not risk assess these women, we will probably miss women who we still need to monitor after 35 weeks, and they would go on to develop preeclampsia. I think that's really very important, and that's the point I wanted to bring about today, was absolute treatment benefit of aspirin declines markedly where adherence is poor, or when predicted risk is low. And the question that is open for discussion is whether aspirin should be used universally, and at some point we lose the effectiveness of aspirin, or whether at this stage there needs to be a bit of course correction and look at what is the best way of risk assessment. I'm not saying that we all need to spend money in risk assessing, but at least make an attempt of risk assessing women rather than just giving aspirin right, left, and center. And of course, ensuring compliance is greater than 90%. Refrain from initiating aspirin treatment without screening and risk assessment. And I guess we would probably have to discuss that. The second part is about clinical management of preeclampsia. When you talk to many obstetricians, they say, well, preeclampsia is very easy to treat because all you do is to deliver mothers. But I think we as obstetricians sometimes forget the amount or the potential of damage that can happen because of prematurity. Because yes, there is no effective treatment for preeclampsia other than delivery, but there has to be a balance between the maternal and the fetal risk. We need to reliably identify high-risk preeclamptic women, and sometimes we may not have the right facilities and they may need to be referred to a tertiary center. We need to have a reliable test that assesses the severity and progression of preeclampsia. And hence, this is where the role of biomarker comes in. We know that there is a strong biomarker, which is S-fleet and PLGF, placental growth factor and soluble fleet, which can be used in screening and detection of preeclampsia. We have seen how PLGF can be used in screening for preeclampsia in the first half of this lecture. But in prediction of preeclampsia and prediction of severity, S-fleet PLGF ratio can be used. Because in women who have preeclampsia, S-fleet increases and PLGF goes down, and hence the S-fleet PLGF ratio increases. And you can see from these two graphs that S-fleet increases approximately 5 weeks before onset of preeclampsia. So that means that before preeclampsia even becomes clinically apparent, S-fleet is high, and PLGF decreases almost 9 to 11 weeks before a preeclampsia onset. So these are two very important biochemical markers that we can use for prediction and of preeclampsia and quantification of the severity. This is a simple chart that basically helps us identify whether women will have will develop, have, or how severe preeclampsia is. So if you do a S-fleet PLGF ratio, and if it is less than 38, then there is no preeclampsia. If it is more than 38 but less than 110, then preeclampsia could develop in the next 4 weeks. However, if it is more than 110, then it is highly suggestive of preeclampsia. So using these biomarkers, we can predict or diagnose the disease first, predict the outcome, because if the S-fleet PLGF ratio is very high, then the disease is very severe, and we also can predict the outcome because we know that very high S-fleet PLGF ratio is associated with poor outcomes like severe fetal growth restriction, fetal morbidity, and in some cases maternal morbidity. So this is a biochemical marker that is very powerful. So till now we have seen screening for preeclampsia, aspirin, and the questions that we need to ask ourselves. And the second part is about use of biochemical markers in screening for preeclampsia. The third point is about how do we predict and translate the power of prediction into prevention. And I give you an example of vasa previa. We know that vasa previa is a serious pregnancy complication. We know that babies die because of vasa previa. Incidence, fortunately, is low. However, today, number of stillbirth continue to happen because of vasa previa. Vasa previa is defined where the fetal vessels are unprotected by umbilical cord, and their course runs within the fetal membranes directly over or near the internal cervical os. We can screen for vasa previa, and the screening is very simple. Doing a transvaginal scan, looking at the cervix and identifying vessels close to the internal os. Some women are at high risk of developing vasa previa. They are women who have had who have placentas that have subscrunchiate lobe, or have low-lying placenta that eventually moves up and has a subscrunchiate lobe. Now, vasa previa is of three types: type 1, type 2, type 3. In type 1, there is a filamentous cord of insertion to the placenta, and this is high risk. Type 2 is where fetal vessels transverse to a subscrunchiate lobe of placenta. Type 3, in which the aberrant vessels enter or exit the same placenta, travel within the fetal membrane to the lower uterine segment. Conventionally, what we have done is, even if we identify vasa previa, there's nothing much we can do. We just monitor them and tell the parents that if you bleed, come to the hospital, but there is a chance that your baby may already be dead before you reach the hospital. We tell them that we will deliver you by 34 weeks. And the reason for delivering 34 weeks is unknown, because we think that, oh, well, at 34 weeks, the baby is mature enough. So let's get the baby out rather than have the risk of stillbirth. And stillbirths can still happen. However, now, if you identify vasa previa, and if it is type 2 and type 3, then you can do we can do laser ablation of the connecting vessels or the vessels that run close to the cervix in type 2 and type 3 only. And this can allow the pregnancy to run up to 37, 38 weeks, because then there is no vasa previa left. And these mothers can even have a normal vaginal delivery. So this is something that is an example of how prediction can prevent a serious poor outcome in pregnancy. Now let me come to obstetrics. And when we come to obstetrics, I just wanted to talk about some of the obstetric emergencies that we deal with on a regular basis as obstetricians. Let's look at postpartum hemorrhage. Postpartum hemorrhage is still a serious disorder, and number of women die because of severe bleeding. And I wanted to bring this up because many years ago, probably maybe around 8, 9 years ago, I came to a cutting edge conference in Bangalore where there was a demonstration of a PPH suction cannula, and at that is probably an Indian invention. However, for some reason it may not have taken up. There is a new device which is pretty similar to what we saw many years ago, 10 years ago, which is now called as the JADA device. Again, I'm not in favor or trying to sell this device, but all I'm trying to show is the principle of how this works. So this is basically a ciliatic ring. Underneath the ciliatic ring is the suction cannula. You can see that very well covered by the ciliatic ring. And it is inserted in the uterus in women who have postpartum hemorrhage. The cuff is blown up, and once the cuff is blown up, it is connected to a suction device, and the suction device remains in operation for almost 1 hour, and it results in the uterus contracting and the bleeding stops. It is thought to be very effective. I know that a number of other interventions such as misoprostol and other things that we have done. We know that misoprostol is not very effective and can be used only in under-resourced country. But this is a good device after you have used Bakri balloon and number of other interventions. And that is one of the new devices that is come that may improve the obstetric outcome. Now, as obstetricians, we all have worked with forceps, whether it's low forceps, mid cavity forceps, and the older generation used to do the Killen's forceps. We know that forceps went into disrepute because of the risk of fetal injury. Then we had the Ventouse or the Kiwi cup, which were supposed to be less traumatic. However, we know that the Kiwi cup also can result in skull fractures. A new device that has just come out is the Odon Assist device. This device was invented in Argentina by a car mechanic, and this basically is applied on the baby's head and slided on right up to the neck of the baby. This is a plastic cup. The outer ring is inflated, and that then snugly fits onto the lower part of the jaw. And this plastic, almost like a plastic bag, is used to pull the baby. And this has the potential of getting rid of all the trauma that is associated with the forceps and other devices. We know that in many countries, and I know if we say that a deeply impacted head is a problem in India, it is not, because probably people are surgically much more trained in India. However, in the Western countries, deeply impacted head is a problem. Second stage cesarean section with a deeply impacted leads to serious complications, maternal and fetal morbidities. And hence there was a device that came in, which was called as the fetal pillow, which was inserted vaginally and was supposed to be pushing the baby's head up. However, there is a bit of controversy about this device. There is a number of papers that have come out saying that probably this does not provide much benefit. Hence, there is a new device that has come out, which is called as the Tidman's tube. It is basically similar to how we push the baby's head up. Have an assistant who introduces the fingers vaginally and pushes the baby's head up when the surgeon is delivering. So instead of putting the fingers in and causing contamination into the cesarean section field, the Tidman's tube is a sterile tube which can be inserted into the vagina, and the baby can be pushed up, and complications of the deeply impacted head can be prevented. Of course, I cannot finish my lecture without talking about fetal therapy and in utero spina bifida repair. This already has shown the potential of preventing and limiting disability, and we know that spina bifida leads to not only mortality but also paralysis of lower limb and double incontinence, the risk of hydrocephalus and VP shunt. And we now know that in utero spina bifida can be done between 24 and 26 weeks. I'm just going to quickly go through this because I think we don't have much of time for the whole one, but this is basically to show that this in utero repair can be successfully done by either a mini hysterotomy approach or by a fetoscopic approach. And the outcomes are good. This is one of the babies, one of the first babies that we had operated on. And this baby already had talipes at 20 weeks when we saw this baby. This baby is now doing well, and the talipes is being managed, but she is leading a good life. And hopefully, this would get corrected as she grows. The top picture is the baby that we operated on 5 weeks ago. She was 27 weeks by the time she came, and you can see how good the scar is when the baby delivered day before yesterday. So that's the power of fetal therapy. we know about prenatal enzyme replacement therapy, and which is new, which is coming in. So if in lysosomal storage diseases like mucopolysaccharidosis, Pompe's disease, Gaucher's disease, we can now, if we can confirm the diagnosis in utero, we can provide them with prenatal enzyme replacement therapy every 2 to 4 weeks in utero till the baby is delivered. And when the baby is delivered, the standard postnatal enzyme replacement therapy, along with prenatal enzyme replacement therapy, has the potential of curing these babies with lysosomal storage disease. Similar intrauterine treatment for alpha thalassemia major, which can cause severe eye drops, is now possible. There are a number of trials that are going on, and in the future, we would be able to treat with these babies affected with these disorders. Of course, we all know about artificial placenta, and maybe in the future, we will, even if women deliver preterm, the artificial placenta would have the potential of supporting the babies till they are mature enough. We know that some disorders are lethal, like severe left-sided congenital diaphragmatic hernia. There is potential that in the future we may be able to operate on these babies and correct the diaphragmatic hernia whilst these babies are still in utero. One of such attempt was made some time ago, but there are still challenges with this procedure, and I'm just going to show you that this is the baby. We give the baby some local anesthetic and open the chest as we would do that in the postnatal period. Once the chest is open, we pull the bowel down from the thorax. You can see those bowel loops. Once the bowel loops are pulled from the thorax, we insert a patch. You can see the patch going in into the diaphragmatic gap, and that closes the diaphragmatic hernia. The bowel is then pulled back into the abdomen and the abdomen closed. Now, there are only very few cases that have been done with this procedure. This procedure still needs to be modified, or more advances need to be made, because the stillbirth rate after post-operatively is higher, and hence there is still some work that needs to be done. But these procedures have the potential of changing the future of how medicine is practiced, and hence I just wanted to highlight these today. I hope I have been able to do justice. I know the topic was a longer one, and I may not have covered a lot, but I just wanted to highlight the potential of precision medicine in obstetrics. That is not there. Some of them is majority of that is already here, but some of that will happen in the future. Thank you, Hema. Thank you for giving me this opportunity.
Thank you for an excellent presentation, Mandeep. Now we want to go on to the Q&A session to be led by the chairpersons for this session, Dr. Milind Shah and Uday. There are some questions in the chat. If Uday or Milind could read that out, and Milind Shah can kindly proceed to make his initial comments as well. This is truly in keeping to the fact that a lot has been achieved, and Mandeep is indeed our pride. Thank you, Mandeep.
Thank you.
It was excellent presentation by Mandeep. A big overview of lot many things which can be done as in fetal therapy, also in prevention of preeclampsia. What we have been seeing for last the aspirin trial, which is to induct 150 milligrams of aspirin right from the NT scan onwards till 36 weeks. But there are few things which probably are still in pipeline. The things are already there. Ki early, severe early preeclampsia can be prevented up to 80% the severity if the continuation of the medication is done by the patient till 36 weeks of pregnancy. One more addition would be it should be at the bedtime, which is the most appropriate time for, because many obstetricians write prescriptions somebody is taking in the morning, somebody is taking in the afternoon, somebody is taking in the evening. That has to be precise. It is 10 p.m. That is at bedtime, which helps because of the surge which is seen is early morning surge, which we want to prevent that surge and the consequences. One more addition, which Professor Kipros Nicolaides and all the team from Fetal Medicine Foundation, they are still working on it, and it's in the pipeline. But it's now ophthalmic artery Dopplers, which we are doing. I was doing as my thesis in Hyderabad, and then we are continuing it, especially for recognition of late preeclampsias, which are more dangerous than early preeclampsias. Here, prematurity, their stillbirth rate and death rate would be higher. So, to detection of late preeclampsias, doing ophthalmic artery Doppler in NT scans, and then after 22 weeks also at anomaly scan and later on is definitely going to be helpful. And probably that in a year's time, maybe it will come in ISO guidelines also. Probably that's what was my talk when we were in Abu Dhabi last year when we spoke to Professor Kepros Nicolaides. Mandeep Singh has added so many things, but he is a pioneer of the fetal therapy who has brought every types of surgeries to the footsteps of India. Now he's performing so many. We saw one surgery, Professor Mauricio and Professor Mandeep Singh performing in our center at Hyderabad, which was an laser ablation, which was the first case in Telangana, which was performed late night at 2 o'clock by Professor Mauricio and Professor Mandeep Singh. We saw it live there. We were present in the operation theater performing such surgeries. Was looking at the hands they were operating was excellent. So probably we were lucky to have those things to be seen. But lot many things he has added in the armamentarium, which is to come. And most important of that, after preeclampsia for us in India is postpartum hemorrhage. And he has said so many things about it. And one important thing which I could gain new knowledge was deeply impacted head. Of course, we Indians are more easily doing surgeries for those things because we are trained for such patients who have come in late labor, deeply impacted head. But new things which are getting added, forceps are going away, and then new things which are added. So many things about fetal therapy, which Professor Mandeep has added, are definitely add to the knowledge of all of us who are present during this webinar. Thank you so much, Professor Mandeep, for adding such things. I was lucky to have visited his center in Abu Dhabi with Dr. Ajit Patil last year, and we could see his workstations and workplace where he's working, and now recently he shifted to
Right.
Dubai. Yeah. Thank you so much, Hema ma'am, for giving me this opportunity.
Thank
Thank
you,
you,
Milind.
Professor Mandeep.
Thank you. Uday, there are many questions in the Q&A section as well as
Yeah.
the chat. Can you just
Before
voice
that,
them
I have
out?
questions. There
Yeah.
are only two questions here.
And there are 3 questions in the, no, 4, 5 questions in the Q&A. Just tap on the Q&A down there. Mm,
Okay, I will do that. But before that, I need to make a few comments. One is Mandeep,
Please.
leaving the starting of where Milind left is deeply impacted head was we have to propagate the Patwardhan's technique at cesarean section and not balloons and not pillows which go down into the vagina.
Yeah.
I think they are unnecessary. If you do the Patwardhan's technique, it is so easy
Yeah.
to develop the fetal head without any trauma
Without
and
any problem.
without any risk. So you have to put that in your lecture. You have to mention Patwardhan's technique and not only mention the pillows and the newer silly plastic devices which they're inventing instead of the fingers. It doesn't make any sense at all. Having said that, the other things were very well done. Like even when you talk about PPH and when you talk about the suction cannula, what has
Action
been
camera.
devised in India is so simple, so easy to use, and we can re-autoclave it and use it. That is a suction cannula which has come from south, and it works on the same principle what you described. But yes, we can have so many variations, like we have even like the Bakri balloon is a variation basically of the hydrostatic tamponade which was devised over here in JJ Hospital in India first by Dr. Shivkar instead of the Shivkar's pack.
Shivka's back.
Having said that, the other innovations like I have some experience with the SLIFT PLBS ratio. And Hema, your question here, factors influencing the SLIFT and PLBS ratio. Yes, both the SLIFT and PLBS levels change much before preeclampsia actually sets in.
Set in.
Now, the first thing which they say is like what Mandeep has highlighted, it is prediction of preeclampsia, with will it occur in a patient or not. Now, the cost of this test is 5,000 rupees, what at least the laboratory which I send over here. And 5,000 is a little too much for us Indian patients to put in for every patient to predict preeclampsia. So maybe in very high risk cases, one can use it to predict preeclampsia. What I generally use is the uterine artery PI, and we can combine it with the regular triple marker test which we do, or a double marker test which we do. But the SLIFT PLBS ratio, Mandeep, I found it extremely useful in severe preeclamptics when you want to know whether to deliver this patient or to wait for a little longer. So in severe preeclamptics, the SLIFT PLBS ratio done in late pregnancy, 34, 35 weeks, or 33 weeks onwards, or 32 weeks onwards, when you want to know, oh, shall I pull out the baby now or shall I not? I have done it in 4 or 5 cases, and whenever I've got a very high result of the SLIFT PLBS ratio, and one of the patients had a high ratio of more than 200, and I was shocked when we got this, because it's a new test for us. We were not doing it routinely, but when I did this in the first case, we delivered the patient and we posted her for a section in the morning, but early in the morning she threw a eclamptic fit. So it is so predictive of something going wrong. There was one case which landed up with accidental hemorrhage. So it gives you a little guideline on how much to wait on a patient of severe preeclampsia. The SLIFT PLBS ratio, at least I have found it pretty useful in our patients here. It is expensive, but I've pulled on one twins right from 30 weeks to 34 weeks by doing the SLIFT PLBS ratio every week and saying, okay, now it is very low, it is not very high, and you know, we can wait. So that was the confidence which it gave me to do it. And another point is, in twins the ratio apparently is little different than what it is for singletons, but like there also the cutoff is 100 and above. If it is more than 100, then you have to deliver the patient within 24 to 48 hours. So that's about the SLIFT PLBS ratio. I'm very impressed by your vasa previa laser thing, which I was not really aware of, and that's an excellent thing. But in which patients, how do I know that this patient will have a problem? Which are the patients which will actually, because it's the rupture of a vasa previa will occur either in labor or just before labor. I don't think it'll occur spontaneously, or will it?
It can occur. Rupture membrane, spontaneous rupture of membrane can lead to the rupture of these vessels. The risk of that happening is pretty much similar to any other woman. But once that happens in a patient with the vasa previa, there is not much of time, because the baby probably just has around 80-90 mils of blood. By the time patient comes to the clinic, the baby will already be dead.
So you would suggest that if there's a vasa previa with other complications, deliver earlier?
No, or else can we do the laser therapy in all cases identifying vasoprevia? Because then it's a preventive, it's a safer. Because you've done the laser, then it doesn't matter. You know, it just carries on, and at least the threat of the bleeding will not be there. Is my understanding correct, Mandeep?
That's correct. That's correct.
Mm.
Yeah.
Okay.
So it basically is a treatment for vasa previa.
Yeah. And then
Then
there's
you
one
can
more follow-up.
continue.
Yeah, please.
Continue up to 37. Then you can continue up to 37 weeks. You don't have to deliver early with or be worried about the risk of stillbirth.
Is there any flip side to doing this laser? Does it require a
It's
super expertise, or we have to call you over, or what should
Yeah,
we
I'm
do?
sure. I'm sure it does require a lot of expertise.
Yeah. So
Yeah,
Mandeep is
Speakeroscopy,
willing
right?
to come, na? Mandeep.
I think the problem is putting a scope inside the uterus, risk of preterm labor. So you might end up having a preterm baby. Obviously, that's an important consideration, because here you're almost inducing maturity. Yes, prematurity is also a problem if within 34. Technically, it is slightly difficult because we're doing it slightly at a later gestation. Lasers we do between 18 and 24 weeks most of the times, whereas ablation of the vessel we do it slightly later, so that we don't induce prematurity and end up into a severely premature baby.
Mm. Right. Uday, there's one more follow-up question by Dr. Sonia on the same topic of S-split
Yes.
and PLGF
Yeah,
ratio.
so there are 2 or 3 questions on
Yeah.
stiff PLBS ratio.
Mm.
One is how frequently should you do the stiff PLBS ratio? It is to be done every week, and that is only if your result is in the intermediate zone. When if it is between 38 to 85, you can do it. You can repeat it next week and see. You can wait for a week, but if it is more than 85, then you have to interfere within 24 hours. And if it is less than 38, then as Mandeep says, you need not do anything, but you can again repeat it if your patient is affording and you want to predict preeclampsia in that. For predicting in late pregnancy, the complications of preeclampsia, maybe you'll have to repeat it within a week. But if I get a value of 38 in a severe preeclamptic, whom I'm worried about, yes, I will repeat it after a week anyway. The cost is 5,000 rupees in the laboratory, which I sent to, I think it's the Algiers laboratory, which they sent it. They give me the report generally within 24 to 48 hours, because I tell them I can't wait very long for the report. And generally, if you tell them the report is available, now it is in Bombay, they're doing it twice a week, or they're running it twice or thrice a week if you send them the samples. I suppose it would depend on where you are. And the other question was
I
Dr.
think here,
Sonia says,
Uday just
excellent
wanted to,
presentation, Mandeep. Still, PLPS ratio is promising, but it is expensive, and time to receive the reports is almost more than a week. So there you are. In some centers, it may take still more time over here to report. Dr. Bellard has said, excellent presentation, Mandeep. I remember a presentation on AMH at Jaipur, whether PLGF in early pregnancy with anemia prevent or reduce the ANC visit. You have to answer that, Dr. Bellard's question.
sorry, could you repeat that
Yeah, whether
again?
PLGF in early pregnancy with anemia, can it be prevented? Can we reduce the ANC visits?
I think there's no connection, is there?
I'm not sure. Or maybe Bellad will have to retype his question because we are a little confused whether PLGF in early pregnancy with anemia. If anemia is prevented, can we reduce the ANC visit? Something of the sort. So we'll leave that for now because he can just repeat.
Mandeep, anything you want to add on the SLIF PLBS
So
ratio?
I just wanted to say that yes, it is expensive at the moment, but there is point of care testing which is going to come out very soon, and it's also there. But also these point of care testing companies need volumes. In fact, there is a company from Hyderabad that has produced this point of care test for PLGFS fleet ratio, which is much cheaper. But obviously, as people get to know and use, these will become much more cheaper. Secondly, I think
Excellent.
it's a test. So the topic was basically today's discussion was mainly about what today holds and what the future looks like. And hence, yeah, absolutely agree. Deeply impacted head, Patwardhan's method, all these are very, very absolutely prevalent, but my intention was to just bring about technologies that have the potential of changing medicine for the future. Hence, sorry, I didn't describe the Patwardhan's method.
I don't feel it is there to do anything more. I mean, now in UK they are evaluating Patwardhan's method, and coming out with a lot of data from there. Once the data comes up, and I think only when the UK gives a chap or a US gives a chap, then we will say, ha, theek hai. These new things, what I mean, I don't think it has got any value. The pillow and the thing. Sorry for that, but
No, but we
your
may
part,
not
yes, you
be.
have done it well. You have done
See,
it well.
any novel innovations, as how Mandeep said 10 years ago when the suction cannula thing was revealed in the cutting edge conference, we all kind of dismissed it off and we said, oh, this may not stand the test of time. Now the JADA has, devices come and then some modifications are happening. So this may be the start of something for a deeply impacted head, which can be done with ease in even in semi-skilled kind of, the operators who are not so experienced with. So one may prefer one method over the other. So all of these have their place depending on who is doing it and where they're doing. And all of us in Vadia, we were using the forceps right, left, and center with ease. Whereas somebody in some other setting, vacuum was a thing, and somebody said, no, no, we'll just go in for C-section because we are not used to instrumental deliveries, etc. So trends are changing. It's just good to place everything on the table and say, hey guys, these are available. do what you want. If you're happy with this, go ahead. Otherwise, you will need to change. There are two more questions, Uday. The first and the second
How
by
is
Radhakrishnan and Archana Matre. Can you just voice that
how is
out?
JADA device superior to SR cannula? That's the cannula which I was talking about, Dr. Pinnaker's cannula or
Panikkar and Samarthan.
yeah, Samarthan.
Yeah.
No, I have no data to show which one is better. I just wanted to bring it out.
Huh.
I think I also wanted to bring out an important point with Hema highlighted. Like from basmati rice to turmeric, we had all of this long time ago, but many other countries came and patented them. Similarly, devices like this suction device, whether it is Wirker's balloon or many other inventions, have come from India but have been lost because companies from
Yes.
abroad have come and patented them or got the rights to do it. And I think we need to do something about it because we're losing not only talent, but we're also losing great inventions
Reputability.
that for.
Yeah. And one last thing about aspirin. Archana
Can
Matre
we,
has asked, Uday.
yeah, can aspirin be started at 22 weeks if the patient comes late?
No,
You are
Mandeep, you're
muted.
muted.
Mandeep, you are
We
muted.
don't,
Yeah.
sorry, can you hear me?
Yeah, now we can hear you.
Uh, we don't know if it will be effective or not.
So it may
It
not
can be
be as
started, but we
effective
don't know
as
if it will be
before
effective.
starting, before 16 weeks is, because technically they say you should start before 16 weeks so that trophoblastic, it has effect on the trophoblastic invasion. At 22 weeks, how much it helps, we don't know, but I don't think there is any harm in starting if the patient has come late.
Now,
And
Dr. Bellard has really elaborated his question. He says if PLGF is more than 40 at the NT scan, that means at 12 weeks it's sitting at 40. Anemia is prevented by IV FCM. So that is one more comorbidity which you have sorted. Anomaly scan is also normal. Is there a need for the 6th month, 7th month, and 30 weeks visit, or can we minimize those visits? I think that's his question.
Sorry, this is in context with preeclampsia, is that correct? If it is
Yes,
less
yes, yes.
yeah, I think you're using PLGF at that stage for screening, and
Mhm.
once it's low risk, then that's pretty much the end of that story.
Yeah, so Bellad is aiming to minimize the visit. That's also in the new protocol of transformative practice because need not have 10 visits, but we need to have 10 contacts, four of which can be physical visits and six can be by telemed and remote connects, etc. That's also what we are trying to play around with and see how the last mile access can be drawn. I'm tempted to ask Dr. Lavanya about the patents because she is a great young innovator in our country and then she's patented a few of the things. So what has been your experience and what is your guidance, Lavanya, for, really make in India and preserve it, patent it, get that disseminated and, make it big?
I feel Indians are the best jugaad people and they should be having the majority of the patents. Because I think as Indians, I think it's imbibed in our nature, and that's how I'm sure Mandeep's got it from the gene. So I think it's very important that, we have good ideas, we have good knowledge. It's just that we fail to follow these protocols. It just comes, I feel, naturally to us, but then we don't understand the legal things of getting it patented, trying to implement it. And I think that is where we fail.
Yeah.
And I also like something you've always taught me, and I'm very glad that I've met Dr. Hema Madam with the very early career of mine. And she says, change the mindset of the providers. And I think that's something very important. I think with this advancing technology, we need to bring up and also, adapt to the new technology that is coming in. That's when we can look into wider perspective, send our patients home with better results. And I think that's very, very important.
Yeah. Thank you so much.
One last question
Yeah,
on
please.
Vasa previa. Veena Acharya asks, isn't it more difficult to intervene in the later gestation for Vasa previa with a bigger baby and larger vessels?
That's correct, and hence we use amnio infusion. So you introduce amniotic fluid, makes it easier to move the baby around, go
Mhm.
and ablate the vessel, and then remove the amniotic fluid as you come out.
So these are like, there would be a learning curve. It would be a challenging, experimentation in the initial stage. And I'm so glad that we have experts like Dr. Mandeep Singh who are one extra effort they are willing to take, step ahead and handhold some of us in our own country. It's a give back time for Mandeep, who does a lot for us. So thank you so very much. The last closing comments by Uday and Milind, please.
No, I think I've commented enough. Thank you, Mandeep. Lovely lecture.
Thank you, Uday. Thank you, Hema.
Yeah,
Thank
thanks
you,
a lot.
Professor Mandeep. Thank you, Hema. And it was excellent presentation for all of us. Thank you so much.
Yeah.
A very big thank you to Dr. Mandeep Singh. That really thought-provoking lecture was brilliant. And of course, the discussion that followed was even better. We now move on to the next part of today's webinar, which is the technique keynote, which will be given by Dr. Shantanu Pathak. The chairpersons for this session, Dr. Lavanya Kiran. It is my pleasure to introduce Dr. Lavanya to you all. As Dr. Hema just said, she is the recipient of the Innovation Award and she is an apt chairperson for this innovation session. We congratulate her for having recently taken over the prestigious position of chairperson of the Karnataka chapter of ISAR. She also heads the Department of OBGYN at KIMS. The second chairperson for this session is Dr. Parag Bhamre. He leads several initiatives in Japaigo and is currently the Associate Director and Technical Head for Cancers at Japaigo. He has already explored the use of point-of-care devices for detecting high-risk pregnancies and believes that technology can really help us leap forward for better care. I request Dr. Bhamre to kindly introduce our speaker, Dr. Shantanu Pathak.
Sure. Thank you so much. Thank you so much, Dr. Purni. Shantanu, are you there on the screen? Yeah, I see you now. First of all, thank you so much, Hema ma'am, and all the colleagues. It was so great to hear, the previous presentation, and thanks for this opportunity to be a part of your constant effort to bring technology for right use in a way in our fields. Also great to see Uday sir and here Dr. Mandeep and Dr. Milind. To introduce Shantanu, first of all, he's a friend in a way. We almost know each other and know each other's journey for more than 10 years now. When he just started a decade ago in one of the districts in Maharashtra, and I'm so proud and so glad to see him, now moving not only within India but beyond India in multiple countries and offering the tech solutions for right usage. As you can see, he's a IIT alumni and has been a founder and CEO of Doto Health. There are many other things that which he has pursued in his long journey, I would say, in the tech space. But maybe we'll hear him first, learn about all the different solutions that he has offered, and then take things forward. Over to you, Shantanu.
Thank you, Dr. Parag. Thank you, first of all, Dr. Hema, ma'am, for always bringing a tech person into the doctors group. I think, as you rightly said, that this marriage is necessary. For me, my learning, I would say, from the clinical terms and a lot of understanding where my friends call me if they have challenge in their pregnancy related issues comes from the lectures that I attend and the technical terms or the clinical terms I learned from here. I will just share my screen and start. I know, and I really appreciate and enthusiasm to be there at 9 p.m. to attend the session and get introduced to the technology. This is, I would say, a golden era for technical people working in medicine. I would more focus on some of the predictive aspect. There are some fundamental digital aspects also which are necessary before we move to the predictive aspect. Dr. Parag, and we have worked on various fundamental aspects which can bring data at first, the quality data first. And then from that data to going to prediction is also a journey. I believe you might have heard the AI summit that happened in India, as well as a lot of innovations are reaching out to you as clinicians or physicians that we use AI for doing something. So I'm sure sometimes you don't like this word also, because in many ways this is black box. Like you have some input and there is some output, and we are defining it as prediction also, and trying to establish how this prediction thing works as well. For me particularly, the learning was that until and unless there is a right appropriate clinical value that is attached to it, and we may solve the problem by even just logic based identification or prediction, but using technology to solve those core problems is important. And when we zoom in, at least from the public health perspective or from the Indian and South Asia perspective, uh, the maternal and neonatal complications, particularly during the birth or immediately after 24 hours, is one such area which has largest impact in terms of maternal deaths. However, as practitioners, you know that if the case would have come early, and Dr. Millen and Dr. Uday also mentioned that we have become expert in handling last case scenarios. This data is a reflection of that many of these cases do not come early with identification of risk or challenges, and then we have to deal with these complicated cases. Now, they can result into various aspects, but we typically see that the delay in risk detection, or when we are talking about intrapartum and birthing monitoring, there are subjective interpretation or inter-observer variabilities, or even the lack in information availability is also one of the aspects that lead to some of the errors. The other thing that we learned is also, when we say that we want to monitor, improve the quality of intrapartum monitoring by, say, partograph, then the assumption that we have that nurses putting all this information set at certain frequency, and then kind of information that is required can lead to fatigue as well. So basically, from technology and the way we see the problem statement is, can we improve the risk detection? Can we reduce the efforts on interpretation and automate them, give you better analysis, help in assisting in making better decision, as well as automating documentation and finding identification and alerts. One of the intervention that very early during COVID, with Dr. Hima, we did India's first study on self-fetal monitoring. That was the need. So how we leverage the technology for situation was one approach. Other thing, we realized that there are gaps in how we monitor the labor, birthing, and postpartum monitoring, and can we save time, increase the sensitivity, as well as predict a certain aspect. So from when we look from the solutioning, it's fundamentally from conception to newborn journey. And whether it is a last mile care where frontline workers are using point of care devices, flagging the risk, or we are monitoring our standard fetal and labor birthing monitoring, but not just looking it from different lens, but looking the fetal and maternal data together, as well as inferring that information with some of the gap that exists today, and how we overcome that. So innovations efforts try to address these problems. What I'll do is, now with this context, we'll try to focus on very specific use cases, and we are able to do that because, first of all, we converted the simple conventional devices into digital. We created an opportunity to identify that data, and now because we have data, we have ability to analyze, interpret, and even predict certain aspect. So one of the problem statement that we are looking at, that, okay, if we have to create access to fetal monitoring, can we detect asphyxia early? Can we, prepare for C-section to prevent the life? Now, I wouldn't go into the case of C-section, right, wrong. That's a different, not my part of debate. But if this is the pathway, then if once I have data, can I look at the new biomarkers which are generated, or the data that is generated by monitoring, and how I can prevent some of the events that exist. On other side, I see lack of standard of care, or standard of practice how to use CTG in a different way as well. And in public health setting, the way fetal monitoring is done versus private, I've seen those gaps as well. And that's where it becomes challenging also for technology to implement, or build something which can be further meaningful. So if we just look at the first pathway, where we are able to look at the fetal monitoring. Conventionally, you have thermal printer paper. Now digital machines have been already introduced into the market. We are proudly one of the largest provider for this, and generated significant amount of data as well. Now this has lead to validation and identification of the fetal monitoring graphs, the pattern analysis, where our aim is that how I can assist in reducing the time, reducing the inter-observer variability to interpret the CTG graphs as well. Now, once we look at the data, and even if I say based upon the study and engagement, we're looking at around 250,000 data sets. In antenatal period, the CTGs, or intrapartum period CTGs, and then classifying them into different conditions, including various kind of alerts, as well as looking at acidemia. So if we are able to reach to a point where I can flag that this is the potential case of acidemia, I think that would be a good value addition from doctors or clinicians perspective. And this is super helpful in cases where this is particularly useful for semi-skilled resources, or there is a gap in the skills that exists in that particular region. So when we are talking about the pathway, what parameters we want to understand from the CTG, particularly say short-term, long-term variability, or even counting the contraction accurately, because there's huge subjectivity in that. So we could just on a higher level, I'm just sharing that we could quantify each of the data set into parameter level basis, and see that what is the distribution. What we are talking about, if I'm looking at around 234,000 data set, then how many STV, LTV cases we are looking at, and create a baseline out of this data. One of the use case I would say is that a doctor in small town in Maharashtra near Solapur had a mother who visited her, identified STV. Ultrasound was done almost 15 days back, and didn't know presence of the loop. She could identify certain patterns where she could clearly see that these are age cases, and because of STV, with her assessment and the older USG, she made a decision and then sent us a video that how this actually helped in making the decision. So if we are becoming because of technology, we are able to give them empowerment to make that decision. This is definitely useful. I will just quickly not showcase the case, but basically she described this as how she analyzed over the night, and then made a decision. And when baby was delivered, she could walk this loop around the neck, and then delivered the baby safely. So for us, that was also an important technological understanding, that how we can be more meaningful. And this was just an example that how we give a detailed pattern analysis and calculations. And basically these patterns keep learning, because first they identify what was and if we keep annotating them against the outcome, they become more powerful. So that is also part of a machine learning, with how data availability can help. So second component I will bring is also if we are talking about the comprehensive labor and birthing monitoring, not only fetal aspect, but looking at the maternal aspect as well. and moving not only to fetal part, but also adding maternal, uh, uh, say tachysystole, hyperstimulation, or cervical action line alert, even going to a point identifying dehydration by maternal heart rate and temperature. So available sensors can actually derive multiple information. We were not aware, as we learn more, and I'm also sharing this for a reason that if you identify such scenarios that, for example, temperature, heart rate could be a good indication of dehydration. Now, this is very simple and known information as a clinician, but we can generate alerts. You can't physically every time go and identify this. Because of the sensors which are available, there is a possibility of generating alerts. Contraction count, some of the devices do provide the contraction counts, but what we realize that the problem goes quite beyond. There is no standardization in terms of how many contractions are there. We ran surveys also among doctors. We just sent images on WhatsApp and asked like how many contractions are there, and we saw that there is a different way of measuring, or the way they are taught, or there is no standard in measuring it. So there is an interesting mathematical modeling work done by NASA, and we try to basically replicate that mathematical model into software and build a count based for contraction. Again, for labor and induction, now with the sensors, it is very much possible to cover as much as labor care guide. And as I previously explained, the care pathway, once understood, we can also provide much insights on the data set that is available. So technology can help you to understand the number of cases you had at your place, what were the patterns there, and actually what were the new learnings as well, how you can improve your care pathway. This was just an example to showcase. Very interesting problem statement that exists still today is blood loss estimation, with a huge inter-observer variability in postpartum cases. So we saw that, when we different methods are used, we ran a survey against a standard known image-based, assessment. And when people responded, the percentage of correctness for estimate based upon different image they saw on the WhatsApp was right from 1.1% to 44%, but nothing more than 50%. That was also something very interesting. So when we try to correlate this, okay, we are doing labor monitoring, we are doing, we need to understand how PPH risk is flagged. And thanks to the revised guideline, I was really happy because my engineering mind was not accepting that we are detecting it based upon the blood loss volume, which actually is the past event. If we are looking at vitals and blood volume together, including even flow rate to an extent, it would give a much better understanding. Now, this data actually helps us in not only identifying, but as we train more and more data with these guidelines, it will actually eventually help to identify or predict. I'm saying prediction of postpartum hemorrhage based upon one of the vitals would be a reality. And there are few examples also. For example, uterine fatigue using heart rate variability has become one of the now new established marker to predict the postpartum hemorrhage. So once we have such tools available, it is very much possible to even predict postpartum hemorrhage using this tool. Now, initially, these tools will have efficacy challenges. So they have to be combined with the rule-based approaches as well as the prediction approaches. So that helps you to, get better view. However, as future we are talking about, these tools will definitely get established as new digital biomarkers for prediction of tools. So talking of future, one of the thing is very important is the quality of data. Are we bringing last mile data or the 0 to 9 months data, intrapartum data, postpartum data together? Then it becomes a quality data bank. How we collaborate with various organizations to predict some of the things. For example, one of the very interesting work where Dr. Hima is also chairman of this study, which is going on, is using machine learning to predict effect of extreme heat on fetal health, but in general pregnancy. So when you have data set, the prediction models could also evaluate some of the things that we could not imagine. Now, how does it help? When you have geotagging of, like, the latitude and longitude of your clinics, you have the devices, data that is generated, that can be linked to various aspects as well. It can also be linked to air pollution for that matter. The one of the work that we are doing with THSTI, Government of India's Institute, is also prediction of small and vulnerable newborn, and comparing the standard longitudinal data that THSTI built against the field level data that Care Mother Toto Health has brought. Now, this has led to a model which can predict preterm birth with around 78% of accuracy as well. Now, these models can actually help in various ways of execution as well. For example, it can help in, just a second, sorry about this. Yeah, it can actually help in deployment of various tools, which I'll just try to show you a model the way. So if we predict preterm or small and vulnerable newborns, even it can act as a good triaging tool based upon either government dashboard or health and information system that is used in the hospital or clinic level, which can actually show that, okay, these are the potential mother with risk. And if not as a clinical decision support tool right away, at least it can help in personalized engagement. So whether in public health or private health, if a risk is identified, there are care pathways which are defined. So this is an example of preterm birth. But if let's take an example of gestational diabetes, pregnancy induced hypertension, simple things like monitoring at home or nudging and educating them based upon the risk is very much possible. And these models are becoming reality also. I mean, they are not anymore like, very futuristic, I would say. They are almost there. We have already started pilots in government facilities or in private facilities as well. So risk prediction is linked to the quality of data, the quantity of data, and the simplification of implementing it. And I will conclude by saying that, the one of the best thing that I learned with clinicians is whatever technology I talk about, they have a simple question. And, a lot of times I like Dr. Hema's approach. He says, okay, this is the care pathway, how it fits in there. I think from technical end or technological end, it is important for us to learn. And this is the question, I think, when you are witnessing new technologies, you should ask that how it fits to the care pathway that you want to see for your patients, and technology must align to that. And I'll pause here.
Thank you, Shantanu. It was a wonderful presentation. You've done justice to your profile. It says you've been very passionate about women's health, digital technology, especially for women, reaching out to more than 2,500, medical people, almost 5 lakhs mothers to be. I think that's wonderful, and it justifies why your machines have been reaching so many commoners. I just want to know, with this technology reaching out to many commoners or the mothers to be, do you also see some ethical or any other unnecessary reporting to hospitals burdening the medical care because they have the devices, or there's home monitoring happening? And any feedback that you have got so far with 2,500 plus doctors using your technology?
So they are using it at both hospital and largely at the hospital, and some of the doctors who feel that it is appropriate for mothers to be using at home, they use at home as well. From beyond the device story, the use cases, I think one, we have that culture where doctors, if they are recommending, they recommend for some clinical use case which they are aware, and patients do follow very religiously on that basis. In terms of the ethical and the regulatory slash, I would say, legal requirements, if I understand correctly, and what I have learned so far from doctors is whether fetal monitoring or the labor monitoring traces are medico-legal documents in a way. So it in fact helps them to have these documents in place. So if patients or some challenge comes, they can retrieve this information whenever needed, and it is digitally available. It is not like, the thermal paper which inks fades away, or you were putting effort in xeroxing it or drawing it. So that has simplified, and that those are the feedbacks we have got. In fact, I would draw one quick and edge case where we were educated by one of the doctor the need of heartbeat coincidence scenario where intrauterine deaths. I did not include that example in today's presentation, but this is how we have learned as a feedback that if you have such technology which can also help us in identifying the heartbeat coincidence, that would be helpful. And we immediately, for us bringing that was like literally 2 or 3 days of efforts, to be honest. But we have received such feedbacks for additional needs for the doctors, and I'm thankful to the community, to be very honest, because we were a bit worried on the digital adoption, and partially thanking the COVID also, where we could witness and demonstrate that it is useful.
I agree with you. I'm very passionate about technology and implementing it, because I always feel technology is like the third eye for any doctor for that matter. And I don't think we should be worried about AI coming in. I feel it's only going to enable us to be more precise and more accurate in diagnosing. And to the example, what you said, I had a similar experience. We had an IUD. And luckily, I practice where the husbands are in the delivering room with the patients. But then, when being prepared for a legal thing, nothing happened, of course. But then we tried to retrieve, and luckily, we could retrieve 7 hours of NST monitoring, because she was in labor for 24 hours. But I think I like that point you said, where you can pick up acidosis much earlier. And maybe looking back at such cases, the other side, for an obstetrician, these are all IUDs are something that they would face very commonly. And if your technology can help pick up acidosis, I think it would also lead into save many more babies. I think that's a very good technology, and you've done justice well, because I feel innovation has to be accessible, affordable, sustainable, and scalable. And I think yours is meeting up all the 4 points.
Just
Nice
one,
resolution.
thanks, Lavanya. All the way from Bali, she has joined this meeting. Thank you so much for
Thank
that.
you.
And enjoy your stay in Bali, anyhow.
Yes, yes.
But then the question that you asked about, does it entail unnecessary visits to the hospital? It's the contrary, actually, because we've been using Shantanu's device called the Baby Beat. It was originally called Fetomax, is the bigger version of it. So the Baby Beat is a small device. We rent it out to the patients in the last 4 to 5 weeks of their pregnancy, when we perceive that they're high risk and they may have to come twice in a week to the hospital to do their CTGs. Instead of that, we rent them the machine and ask them to do it alternate days. By Bluetooth, the reports comes to us. If we give them a thumbs up, they're good. And if not, we'll say, come to the hospital immediately. So in fact, it reduces the number of visits, and it's very, very reassuring. And any class of patients, because some of them who are really at high risk, though they cannot afford, they'll book into centers like ours because of the previous losses, etc. So they also, within 2 to 5 minutes, the staff teaches them how to use it, and it's so very user friendly. On the contrary, the level of healthcare providers like ourselves, our peer group, not much enthusiastic about using technology. That's what I wanted to ask Shantanu. How has been your response with the generations like Lavanya's, and even next to that, compared to our generation in adapting some of the newer devices that you are bringing in and the concepts that you're throwing ahead? Shantanu?
Yeah. No, we have mixed reviews, because I have very young doctors who are using, and sometimes they are like, okay, we anyways manage this. And I have you, Dr. Sanjay Gupte, who are using home monitoring since last 4 or 5 years. So it's just I think we need to create more awareness on the clinical use case. That's where most of the time physicians get convinced, and we are also step by step learning that how we build those use cases, generate more evidence, but appeal to all the physicians that it is now much proven technology. And I'm not saying only for my product per se, but I'm saying that there are innovations which have demonstrated at scale, and now they have become a solid tools which can assist you. So explore, and more than happy to have more conversations on these fronts to share what is new and how it can be useful.
Shantanu, what is the
Shantanu, I
cost
would
of the
say
machine? What is the cost of the machine?
It's sir, most of the OBGYNs are super comfortable in buying, and rental also mothers
Possible.
will, yeah.
Yeah. Because initially I was working with Manyata for almost 6, 7 years. Parag, we have met so many times, and then I left and I went to fetal medicine. But I'm still interested. People around me, like in Satara, we have remote places where people. Now I will introduce in the next meeting about this machine because I don't think anybody in Satara is having this machine.
Dr.
So,
Gadge is
what
using
figure
it,
I should
but
quote
yeah,
around?
Yeah.
yeah.
Parag?
Shantanu, I would like to definitely try. So you should meet me.
Sure,
But
sure, I
Hema
will.
ma'am, I have a question for you.
Yeah.
You said you've been using this. Did you see that your section rates increased or anything? Because we're picking up much faster. Of course, I understand the outcomes of the babies are much better. But then did the section rates or intervention rates increase, or did early inductions happen?
No, overall speaking, the kind of setting that we are in to err on the safer side rather than the risky side, many of these high risk cases we are posting electively for section. So it's a planned section. But then sometimes when this intense monitoring is done, we may ourselves decide that no, we will not wait a week longer or we will not wait 3 days longer. So the mode of delivery is kind of prefixed and predetermined in most cases. That's my experience. But then when we do the intrapartum monitoring, for example, or induced cases, then I think really this is reassuring for us that we are not late, we are not missing anything, and we are okay for waiting for the said amount of time, because without this, maybe we would have hurried up a little more, or, just after 1 or 2 hours, we get restless and we say, no, and also the staff training, the task shifting for adequate monitoring. You can never place your finger on where what goes wrong, because the team has to be really well trained and honest in their feedback on what is happening to the patient at the frequency that is defined. Whereas things like nurtura, if they alert, if they signal, and also ambulation is one of the key things in the present labor rooms, and many of Shantanu's devices like the temperature recording or BP, she can wear it and move around everywhere. So all these are interesting findings. We are still in the exploratory stage. We don't have sufficient data to see with or without how better we are doing, but we are doing and defining our intervention with more of the timing accuracy as well as the confidence. That much we can say, that that mind set is slowly beginning to have the trust in what we can decipher from these equipments. But Parag is waiting for a long time. His hand is raised. Yeah, please, Parag.
No, no, ma'am. All pleasure to hear you. I just wanted to, point out some three things in a way, and we all that in a way kind of summary of what different speakers maybe were saying, and also to add what is happening in public sector, because as you know, we work very closely on similar solutions for public sector. And the first thing is, Shantanu, you'll be happy to hear that last time when we presented together in Cutting Edge Conference, that time I was talking largely for AI readiness. But, I want to say, ma'am, and again to respond to how technology will be adopted. There are currently, let's say, NHM Madhya Pradesh, who have actually asked us to deploy these algorithms in labor rooms of public sector hospitals.
Nice.
So what Shantanu presented, and what I liked, he said that, but maybe I'll just articulate it like it's a problem first, right? So what he's trying to probably do is to solve that problem first, whichever product you have with you, but solve that problem of workflows, right? And we all are seeing in our practice, we are seeing it in public sector, the burden and the, the chaos that happens. But ma'am, I'm glad to share that these solutions are getting accepted by leaderships of these states. And in fact, they've asked us to implement it in a couple of districts at this point in time. They have given us a formal mandate. So why I'm just sharing it here, because, the adoption is faster than we anticipate. The adoption is faster than individual level, because the ecosystem is really moving faster towards it.
Very nice.
I only have one more submission, Shantanu, and impressed with some of the work that you presented on climate with Madam's leadership and also on SVNs. My only submission is currently there are big initiatives getting launched by ICMR on SVNs, on single digit newborn mortalities. How do we find out, or how do we make your proposals for those interventions? Because, you know, that will really align it well. Because they are also focusing on identifying geographies where single digit newborn mortality is a dream for the country, right? So how do we, you know, align these different initiatives of different sector leaders, and then take it to the ground so that, you know, the impact will be amplified. That's one submission. And I think,
Sure.
Chandru, we spoke about it earlier also, but how do
No,
we
and
make it?
thanks to Dr. Hema, so that we are for 1 hour we are in same space and we are able to bring these ideas. Definitely, you know, the one of the good part is that ICMR, THSTI, Japaigo, one or other way, we are talking about this, and if we can actually create that platform where, you know, at least in MP, as you said, if we can test some of these things, that would be really a good platform to have. But ma'am, also from private healthcare provider, I would love, this is not like I'm asking in a reverse question here to see that the speed at which now government is adopting things. Maharashtra last week announced Maharashtra Health Technology Mission, where they are also talking about faster adoption of this technology. How private care providers, and what would be better pathway or guideline, and this is question to the chairman of the panel also, to how technology people should reach out, and convey the message in a right way also, that would be helpful for us.
Yeah, I think Shantanu, slowly and steadily, we are realizing that we are already late in adapting this. You know, we should have been much more faster, where girls, women themselves in all other segments, they are way ahead. You know, they are the ones who are demanding, seeking us to adopt more technology as providers. You know, so it's happening like that. So that's what the demand generation from the consumers, so to say, the population itself will make us pull up our socks and just get moving faster than what one would have expected. But we are definitely a little slow because we are guarded. We don't know how much to rely on technology. What if we miss something? So it's slowly and steadily, with more validation, with more use cases, as you always say, and with large data. And I had raised another question in the chat box, saying that our terminology is only so bizarre that anybody puts, if a placenta previa, there may be 2, 3 different things: pregnancy-induced hypertension, preeclampsia, this, that, and the other, hyperglycemia, pregnancy, GDM, GGI. The terminologies are so kind of mixed up that even machine learning may become actually difficult, because the consistent usage of the same thing is not there, though the cases are there. That is one barrier that I have noticed. And another important thing is that the different geographies, will respond differently. We already know that. Okay, so whatever is best possible in whichever geography, just let's get moving with that, because it may look slow, but the time runs very fast. And I think very soon, most of these user friendly is one thing, adding value to the decision making, task shifting, as Parag always, that's a buzzword we have learned from Japaigo, semi-skilled people can use, because too much you just come to the neck of the consultants, how many things can they do? So if there is some flagging, some clutter that is freed up, then they say, hey, now this machine is also there, my staff is also there, she will be able to alert me on time. That confidence building is going to slowly happen. So I think that is perhaps the way forward. And the cost effectiveness and the feasibility of usage, and how many errors can come in, how we just, disseminate this, unlock the potential, as I always call it. So there is work to do, but we are at it. The forums like these are also, giving us the confidence that, yes, these are hundreds of people watching this. They are, slowly into this space, but we have to sensitize them, because they don't know perhaps what we are missing if we do not lap up the technology. And I think in India, we are doing much better even in these spaces compared to the West. So we are again, really happy about that. Yeah. Parag? Mm.
No, great. I think, ma'am, I think you covered most of it, and thank you again, Shantanu. I see Divakar sir is also here, so maybe, if you're at the end of this session. But I do see, few comments or questions.
What does it say, Parag?
Madam covered it, right?
Yeah. So that
Yeah.
is that is some questions were raised by me, only question answers.
Yeah,
Because there are, unless we raise these questions and discuss it openly and not be fixated in our ideas, because we can't see, always the hybrid approach is the best approach, because we can't totally hook on only to technology. We can't totally hook on to meet and touch and feel kind of a situation, because it has to be ultimately the mix of both. But chronic care can definitely be, the follow up can definitely be, interpretation of the laboratory reports can definitely be, point of care immediately giving you the results, and the barriers for the follow up, loss to follow up cases being minimized. There are already ever so many advantages that you can see. So why don't we at least start using these to our advantage? And slowly, when the robust, application of all these things are there right across, I really want our country to lead the technology transformation of women's healthcare in a very, very big way. In FIGO level also, we've been speaking much about it, and most of the organizations globally also are looking towards India for the implementation. And they say that if India can adopt it, why can't we? So that is how, the trend of thoughts is moving ahead. So I think it's a good thing to raise these in between ourselves first, and then open it up to the rest of the world. And you saw Divakar there, because I've insisted that on behalf of Team Artists, he must make a formal thank you to all our distinguished speakers. So Divakar, over to you. Divakar is muted. Yeah.
Good evening or night to everyone who are attending till late night. On behalf of Artist Farrar and Dr. Hema Divakar, the program director of this webinar, I thank all the faculty, Dr. Mandeep Singh for his insightful talk on the early prediction of high-risk pregnancy, and Dr. Shantanu Pathak for discussing predictive health tech in maternal care. Chairpersons of the first session were Dr. Uday Tanavala and Dr. Milin Shah, and second session were Dr. Lavanya Kiran and Dr. Parag Bramre. I thank all of them for attending today's webinar. I thank the organizers, Format Limited, who are the sponsors and the organizers of this webinar, and today's conveners, Dr. Rita Singh and Dr. Puni Narayan, who are from Artist team. Thank you all for attending today's webinar. Thank you all very much.
Thank you, Divakar. Namaste, everyone. Thank you so much.
Thank you.
Thank you so much, ma'am. We enjoyed. And anyway, Shantanu, it's not 9:30. I'm at 12:30 now.
Yeah, I could imagine when. So hats off to you. Thank you.
It was nice. It was nice meeting all of you and listening to all of you.
And
Wonderful.
I'm so happy that most of you mentioned the cutting edge as start point for many things. So we are still on the same track, moving ahead to just see what can work and what fails. We are not afraid of failures. So we take the foot forward to see what best we can do. We may fall, but we will rise again. That is the promise that we are making to ourselves and to the girls and women of this country. Thank you very, very much once again. Namaste.
Thank you. Thanks.
Thank
Bye.
you.
Thank you.
Thank you so
Thank
much.
you.
Thank you.
Thank you.
Bye.
Thank you, ma'am.